Hi, I'm Nancy Block from Private Label Surrogacy, and I'd like to introduce Gaby, who is an embryologist who is working at Bloom Fertility, and she'll tell you a little bit about herself. But today we're just going to educate you on a few basics of embryology, and feel free to reach out to us at any time, privatelabelsurrogacy.com, Nancy at privatelabelsurrogacy.com, and now I'll have Gaby just introduce herself and talk about what she does.
Hi, I'm Gaby. I'm the founder of Bloom Fertility, and during my time as an embryologist, I found myself spending hours on the phone with patients, friends, family who were doing the IVF process, and they found themselves to be lost and confused. So I decided to start Bloom Fertility to provide the support and education to empower patients during their process, because I believe that is helpful to achieve a pregnancy.
I think it's great that Gaby has started this program, because I don't know, and I've been doing this for about 25 years now, and before that I was a nurse, an OB nurse, so I've been around, and I don't know of any other embryology group that focuses on optimization of the experience for patients so that they understand, and maybe even egg donors and maybe even surrogates as well. So we'll start with a few questions, and hopefully you'll get some answers out of this and enjoy our video. So Gaby, thank you for being here.
Thank you for having me. I'm very excited to be here.
And we're happy to have you. There are a few questions I'd like to ask first, and then we'll get into more complicated questions. And let's start out with, for instance, how many embryos do you need for a successful pregnancy?
So that's a good question, and an ideal number depends on the factors such as age, egg quality, sperm quality, and family planning goals of a patient. And another factor that we at Bloom Fertility believe is that being educated and knowing how to advocate for yourself improves your chances of attaining that number and achieving a successful pregnancy.
Thank you, that was really helpful. So basically, what does an embryologist do after an egg retrieval?
So after the eggs are retrieved, that's our time to shine. We get the follicular fluid from the OR, from the physician doing the aspiration, and then we look through the fluid, find the eggs. Once the eggs are found, we will assess them for maturity, clean them, and then we inject them, and we put them in an incubator for overnight culturing.
And you inject them with?
We inject them with the sperm, and that's called ICSI. Most patients choose to do ICSI. Some do conventional insemination, but most of the patients that I've worked with do ICSI.
Okay, and is it the doctor's choice too as to how the eggs are going to be fertilized?
Yes, so the treatment plan is most often determined by the doctor unless the patient has some sort of specific requirements or wants to try something different, and also it depends on whether the patient has a male factor. That's kind of how it's determined which way we will inject or inseminate the eggs.
Okay, sounds good. And does everyone test chromosomes for each embryo, and then who decides?
So basically, ultimately, it is the patient's decision on whether or not they want to do genetic testing. But I recommend my patients to do that if they have had recurrent miscarriage, advanced maternal age, or if they have a known genetic condition. That is usually helpful information to get that genetic testing done. However, ultimately the decision is between the patient, the physician, and the fertility care team.
Okay, got it. So everyone will have a consult with you to decide what to do, and then eventually things will move on, and they move pretty quickly in embryology, right? Because you fertilize usually when they're retrieved, right?
Most oftentimes these decisions will be made prior to the treatment cycle starting. So we know exactly what's happening and there's no confusion in the lab, which is helpful.
Yeah. Yeah.
And it's helpful to have this information for patients to determine so they can choose a genetic testing company. And then we also know what's going on, and we can send the cells out to a proper lab as well.
Okay. And about how long does it take to get those results back?
Most companies say around 2 weeks.
Okay. And I know the costs vary, and it is expensive. Are any of the costs covered by insurance that you're aware of
I am
for PGT or PGD or any genetic screening?
as far as I know, I don't think that they are covered. However, I might be mistaking.
I haven't seen where they're covered. People haven't let us know. When we work with intended parents and surrogates, usually the intended parents will talk about things like that, but I haven't heard where insurance will cover.
I have not either in my experience.
Okay.
In that.
Thank you. So what are some of the questions that somebody might ask if there are not mature eggs or mature eggs to fertilize for a journey or a cycle?
So during ICSI, the embryologist most often takes notes on egg quality or sperm quality if there are any issues that they can visibly see during the process under the microscope.
Okay.
I think that's the first step in asking, were there any notes on my quality of the eggs, quality of the sperm? And then something else that I think is important that I tell our patients to ask is, what stage of development did the development stop?
Mm-hmm.
So, there's times where I'll take out embryos and unfortunately on day 5, they have not even cleaved from that initial fertilization stage.
And what is cleaving? Even though I know it and you know it, they don't know it.
So basically cleaving means that there's cell division occurring.
Okay.
And so it's helpful to know, did my cells stop dividing at a cleavage stage where we can count the number of cells? Did we not even have cleavage? So that means that only we can still see the pronuclei from fertilization. So those are important things that I always advise our patients to ask.
Okay. It's good. I mean, knowledge is power, definitely. And it's important to know what you're going through when you're going through this, especially because of the cost of everything that's involved. Even if you don't work with a surrogate or a donor, it's really important to know what you can know when you're going through a journey.
Absolutely, and it's super important to help advocate for themselves as well to do that.
I agree. So how do you know if the eggs become fertilized, and when do you know that the eggs become fertilized?
So everything is timed in the IVF lab. So this fertilization is checked 16 to 18 hours post-injection.
Okay.
So we come in the morning, we'll get ready for the day, and that's the first thing that is checked from yesterday.
Okay.
And we look for specifically 2 pronuclei, one from the egg, one from the sperm. And if both are present, which is visible under a microscope, then we consider that their fertilization has occurred.
Okay. Is that big microscope or just a regular microscope?
Some labs use a smaller microscope, some labs use a bigger microscope. I think it really depends on which the embryologist is more comfortable on.
Mm-hmm.
Just so they can, for sure see the pronuclei and determine fertilization properly.
And when they fertilize, I have seen this and I was amazed, but when they fertilize an egg, and they do ICSI, when they inject the egg with the sperm, it's amazing how these machines work because they're so huge, and you move these little wands like a millimeter or centimeter very, very slightly, and it does amazing work. So you really have to be talented to be an embryologist.
Yes, absolutely. It's a very interesting and hard line of work, but it's also super rewarding, and all the machines and everything's so small. It's wild.
It is
what
wild.
Can be done just after a few minutes of injecting.
Yeah, if you're ever offered the option to view fertilization, take them up on it. It's really interesting. Okay, so I have a few more questions. Well, actually quite a few more questions, and we can start here. What is the difference between a day 3 and a day 5 embryo?
So the biggest difference between a day 3 and a day 5 is where the embryo is at developmentally. On day 3, we will check if the patient requires us to check that day. We will only be able to count number of cells. there won't be a cavity forming yet, as opposed to on day 5, the embryos should be already at a blastocyst stage,
Okay.
and that's where you will see that cavity. So that's the biggest difference. And what we look for is how many cells there are on day 3. We usually want to see 6 to 8 cells, and we don't want to be able to count cells on day 5 already.
Okay, so a blastocyst is like a whole bunch of cells all together, so you can't really delineate
Right.
a cell.
Right. It's
Okay.
more, yes.
All right. So how are the cells taken from the embryo when they go for genetic testing, and how are they sent out?
So this is a very meticulous process. It takes a lot of skill to be able to do PGT biopsy in the lab. And what happens is once the embryo has an ICM and a trophectoderm, we will go in with a special needle and take out 5 to 6 cells of the trophectoderm.
Oh, I didn't know that. I thought it was only a couple cells.
5 to 6,
Okay.
super small. We don't want to disturb the embryo. We want to just take out as little as possible without disturbing. And those cells will be taken out of the embryo. We will then, there are special tubes that the genetic testing company sends. And then there's a whole process where there's a witness for how they're labeled, because you need to be careful with which cell is going into which number. And then each cell will be put into the specific number in the tube. They will be put into the freezer, and then we send on dry ice to the genetic testing company.
Okay. Does everyone send out their embryos for testing, or do some do the testing in-house?
As far as I know right now, most places send out. I don't know of a clinic that does in-house testing yet. We usually send out to different types of clinics or laboratories, depending on where the patient has chosen to send them out to.
Okay, so patients have choices, and there are about how many locations for patients to have their embryos tested for PGT?
Several locations, and really depends on cost, which clinics work with specific labs.
Got it.
And then if a patient wants to do further testing, there's a few places that are specifically for PGT A&M testing.
Okay.
And that's just determined by the physician and the fertility team.
Got it. So there are a lot of variables, and you do need to understand and be educated by either an embryologist, which is always the best, or your physician, I think. Okay, next question. How do you monitor development of an embryo in the lab?
This is an important question. I get asked this a lot by my patients. So as much as fertility patients want to know what's going on every hour with their embryos, it's best to not disturb them. So most of the time we will look at fertilization. After fertilization is assessed, embryos will not be taken out of the incubators until day 5, which is the first day that they would be checked at the blast stage. And then again on day 6. If some clinics check on day 7, they will culture until day 7, and the embryos will be checked again then. It's important not to disturb them, so we really try to limit the amount of time we take them out and check them.
So when you take out the cells, I should have asked this earlier, but when you do take out the cells for testing, on what day is that done of growth development?
The first time that we can look at the embryos for potential biopsy is day 5.
Okay.
And then if there are no embryos that are ready on day 5, we will put them back in culture and check again on day 6. And some clinics will do biopsy on day 7. That varies from clinic to clinic.
Okay. Understood. And when will I know, or when will a patient know, how many embryos he or she has for use?
Most of the time, embryologists will give a patient a call on day 6 or day 7. It just depends on which clinic they're working with and what their protocols are. That's something that at Bloom Fertility, we can help our patients determine if they want to culture out till day 7, which clinic could be helpful with that, which clinics don't culture out till day 7, and sometimes the embryos just need some more time. That's my experience. I have seen that day 6, they're not ready, and then we let them have an extra day, and there's embryos to be biopsied and frozen. So I think that sometimes, having that extra day is helpful, and finding a clinic that will do that is also helpful to a patient going through the process as well.
And that brings up a question that I would like to ask, and that is, we do work in surrogacy, and sometimes the patients that we work with, the clients that we work with, have only one embryo to transfer, and they're unable to create more. What could be the success rates with a good quality embryo, a receptive uterus, someone whose lining is thickening well and following all instructions, taking all of her medications the right way? What are the chances in most cases of a single embryo having success with creating a pregnancy?
In my experience, that's always very stressful. When I've worked with intended parents and gestational surrogates, there are so many factors to put into this question and answer. It depends on, the maternal age of the eggs when they were created. It depends on the freezing process, the thawing process, how the transfer went, so that's why it's important to know where you're going, what clinic you're working with, what their specific success rates are for freezing and thawing, and what their success rates are for implantation and transfer rates. That's something that at Bloom Fertility we help with, and our goal is to make sure our patients are educated on where they choose to do these transfer processes, because there are so many variables that need to be taken account to have that successful pregnancy.
Right, like the slow freeze and the fast freeze and the slow thaw and the fast thaw and the new technologies. I'm sure that they pop up all the time, and everyone does have their own way of doing things. And I'm sure physicians and embryologists have recommendations. So there are a few more questions that I'd like to ask, and that is, what inspired you to become an embryologist?
When I got done with college, I was offered an opportunity to go observe in an IVF lab. I had never been in one before. I didn't know much about what it entails, and I was absolutely amazed. It was wild to be able to see the sperm under the microscope, how meticulous the process is, and being able to see like the embryos develop and seeing people attain a pregnancy from, everything being done in the lab. I thought it was amazing.
And so you were always into science?
Yes, I was always into science. Yeah. I just never really thought about doing IVF until I actually experienced it and got the opportunity to observe what happened. And I thought that it was wonderful and amazing to be able to do what I love and also help people attain a pregnancy.
Amazing. And what specific tasks do you perform as part of your work on a daily basis?
So I'm a senior embryologist, so my day-to-day tasks look like we get into the lab. First thing is we'll check fertilization, and then I am responsible a lot of times for doing biopsies, and that's also done in the morning. So morning time is basically check embryos, do biopsies, and then our afternoon looks more like inject eggs with sperm, and that's kind of the day-to-day.
Got it.
Yes.
Got it. And they are all in a petri dish, and they go to an incubator, and they're stored and labeled, and everything's very protected. And,
yes, everything is properly labeled and stored properly. 2 identifiers, always very careful in there with all of our tissue.
Okay. And I think you already did talk about some of the rewarding aspects of being an embryologist, and if you want to elaborate outside of, successful pregnancies, I'm more than happy to listen, and I think our audience might be happy to listen too.
So something that is rewarding to me is first and foremost being able to help people, and I think just, from my experience with my friends and with family, being able to support them and provide that extra education for them is helpful, and seeing actually a lot of my friends get pregnant. And that's been super rewarding. And on top of that, it's just, even if I don't know the patients I'm working with on a personal level, just being able to provide that support and help them and give them that empathy that they need to actually ask the questions. I think that that's rewarding, is helping other people and being there and also helping them get pregnant.
I couldn't agree more, and I think that it's really important to have somebody who will listen to you, and I think that's what, you know, Gaby is talking about. And you know, obviously a good surrogacy agency will listen to surrogates and clients, and even if you work with donors, of course, just someone to talk to and someone who's going to listen and understand and explain things. So I think we've asked some of these questions. Let's go for one more. What are the latest breakthroughs or technologies that have transformed embryology in recent years that you can think of? I mean, you're seemingly young, so I don't know how long you've been doing this and how much new information is out there. So if you can explain, you know, maybe how long you've been doing this and what new technologies are out there, would be great.
I've been an embryologist for 10 years. I also got my master's in reproductive clinical science from Northwestern. So I got to get that aspect of lab work from Northwestern, and then I've also done my time in the lab at the bench, which is helpful to, you know, see all the developments that have occurred in the field. Something that I know is about to be happening is AI for grading embryos and determining embryos for transfer.
Really?
I don't know how far along that is. Those are just, you know, little conversations that I've heard on the side and read about. But I think that that will be interesting, and I'm curious to see how that will be implemented into the lab and bench work.
Boy, AI is into everything. How do you ensure the highest quality and viability of embryos during your work?
So basically, high quality embryos, we assess them in the morning. Something that I look for is, are the cells even? Is there fragmentation? And something else that I look for, if they're not day 3 embryos, is day 5. What does that inner cell mass look like? What does a trophectoderm look like? I'm a pretty strict grader. I like to make sure that the embryos look nice and they're developing the way they should be, just to ensure that, you know, the patients that are going through the process actually have good embryos, and that they are, you know, eventually will hopefully be able to be used for a pregnancy.
Got it. Can you just define trophectoderm?
So trophectoderm is the outside of the embryo, and that becomes the placenta.
Got it.
Yes.
Okay, that's helpful. Let's ask one more question about safety. What measures do you take to prevent errors or contamination in the lab? I'm sure this is a biggie.
This is a big question, and it's asked often, rightfully so. So in my experience and in the labs I have worked at, it's super important that everything is labeled properly. There's 2 types of identifiers. We also make sure that there's always a double witness, which is, in my opinion, super, super important. Something at Bloom Fertility we tell our patients is that it's important to find a clinic that takes that very seriously, because obviously you want your tissue to be labeled properly and handled properly. So a double witness is super important, and making sure everything is labeled properly is super important.
Great. Okay. And then when someone goes in for an embryo transfer, what do they see? Because oftentimes there's a screen with a picture of the embryo, and it's labeled. So can you kind of describe that process?
What we do is there's a special transfer dish that is made when the patient is in for a fresh transfer or a frozen embryo transfer, and that dish will often have patient's first and last name. Another identifier depends on the lab. It could be an MRN, or it could be some sort of other identifier.
Medical record number?
Yes. Oh, yes.
Okay.
I apologize. Medical record
That's
number.
okay.
And then usually the clinic will show the patient the dish prior to the transfer, and they will have to okay it on the OR side and say, yes, that's me, that's my embryo.
Okay, because during an embryo transfer, which I have been at, you don't really get put to sleep. Sometimes they give you some oral Valium to relax you, but you're awake, and it's really a a very quick procedure, but it's obviously very precise.
Yes, I would
Okay.
agree with that.
Okay. So whoever is in there, and if you're working with surrogates, sometimes intended parents are able to go into the room for the embryo transfer.
And a lot of times when it is a surrogate and an intended parent, we will have both of the patient's names on there just to double ensure that this is what's happening. And at the window, in those circumstances, we will also identify both sets of patients, NIPs and GCs if they are there.
Okay.
To make sure that everything is, good to go and everyone's aware of the plan and okay with the plan.
And it doesn't matter if it's man or woman, everything is labeled exactly with the right
Absolutely.
identifiers.
Absolutely.
Okay. How do you choose the healthiest embryo if intended parents are not deciding on, let's say, the gender of the embryo, and they say to you, tell me which embryo to transfer? How do you know what embryo to transfer?
I advise my patients that come to us at Bloom Fertility to always choose the A embryos if they have them. So, and in my opinion, I think that a 5AA, if the patient has, is always a better option. 5 is referring to a hatching blast, is better than a 6, which is a hatched blast.
Okay.
And
so it's coming out.
It's coming out of the zona, but it hasn't come out of the zona yet.
It's starting to. Okay.
And something else I advise the patients to look at is choose embryos from a younger retrieval if possible. So if they've done banking, I always say pick your eggs, pick the embryos made with the youngest eggs. And then the next thing that I tell them to look at is the number, which refers to the size of the embryo.
Okay.
And then I will tell them to look for the A or the B, or AA or BB, depending on what the gradings that they have are.
Okay.
And then I would go from there. But I always say, first and foremost, youngest eggs, and then look at the number and then the grade. That's how I...
And what if there's PGT or PGD testing, depending on the facility? They call it different things. But it's basically genetic testing on an embryo. And how many tests how many disorders do they look for?
So there's patients who will just do PGTA, which is for aneuploidy, which is just, the full set of chromosomes, whether or not they're present, or if there's something missing. And then there's patients who come in who have a single gene disorder or have like 2 or of known mutation. So there's times where they'll do PGTA and then PGTA-M. And that just depends. I've seen patients do PGT-M for 2 known conditions. So it really varies from patient to patient and what their, health background is.
So when we work with surrogates, many of our intended parents are doing as much testing as possible because obviously this is emotionally and financially draining to a lot of people, and it's a lot to go through, and they want to make sure that they have the healthiest embryo. So when you check for disorders, how many can you check for? Like how many disorders do they check for at most? When they do the biopsies on the embryos, like 300, 340?
They can do a full sequence. The labs can do a full sequence of the gene analysis. They can do all or not, basically whatever that the patient wants, yes.
What's the most that you could do, depending, and you may not know because there might be labs that you don't work with when you send out the chromosomes for analysis, but what is the top number that you've heard about that of disorders that people can check for?
So I think it depends on the lab. I don't have a specific number because each lab will do, some labs won't check single gene disorders, some will. So I think it varies on the lab.
Okay.
And that's an important factor to be educated on based on what the patient wants to be tested and what information they're trying to gain from that genetic testing.
Okay. So that's a good question for you,
yeah,
an embryologist, maybe versus the fertility doctor, or if you're not available, then you do talk to the fertility doctor to find out what testing is done and how much. Okay. And let's see what else we can ask. Just a couple more questions. Where do you see the field of embryology heading in the next decade? And I think you slightly answered this before, but it's still helpful to hear again because we don't always remember everything we hear, especially when we're getting knowledge of things that we're not comfortable with, that we haven't been educated on.
I think AI is definitely going to have some sort of involvement in the field in the future.
Mm-hmm.
I do think that there is something about hands-on in the lab by trained embryologists who have a lot of experience, dealing with embryos, dealing with the tissue, dealing with all sorts of tissues, because a lot of times it's not all, perfect. There's times where the sperm, there's a huge male factor and it has to be, the sperm has to be picked out meticulously based on the morphology and the motility, which is super important. So as I do think AI, I'm sure, will be somehow involved in the process, I do think there's something about, the human aspect of finding the correct sperm, putting in that extra effort to inject those eggs, and really working hard to make sure that we optimize a patient's chances of getting pregnant by our experience and our education in the field.
Got it. Okay. And I know there are different age cutoffs for different fertility centers, so we're not even going to go into that. And many people do work with egg donors because they're above a certain age, and they do think that, fertility physicians and embryologists think that patients have a better chance of having success with younger eggs. That doesn't mean that people who are a little bit older won't be successful with their own. It just means with a donor, or if you're working with men only, obviously you need an egg donor. They do look at age, and sometimes, all it takes is one embryo.
Absolutely.
What do you wish for what do you wish more people knew about embryology and what they understood about embryology?
I think that this is a good question, and I think that it's important to be educated in the topic, especially when going through it. I think it's such a complex and long process, from the start of the period to then getting to the retrieval, and then making it through that process of culturing the embryos. So I think it's important that people, get that extra help if they need to understand things better so they can advocate for themselves, and get that support to make sure that they are optimizing their, ability to get as much out of their cycle as possible, since it is such a daunting, emotional, and expensive procedure.
I want to thank Gaby. I know she, who was sitting right next to me, gave a lot of information out, shared a lot of her knowledge, and if anyone has any more questions, they can reach out to me or Gaby, and it's Nancy@privatelabelsurrogacy.com. And Gaby, if you're comfortable giving your email address, that's fine, or they can reach out to me and I can send the question to you.
It's info@bloomfertility.org.
Okay.
So please reach out to us if you have any questions.
Okay. And we will continue this discussion. And if anyone has any questions, please send them to us and we will address them and send more videos on our channel. Thank you for joining us.
Thank you for having me, and thank you for joining us.
Thanks, guys.